A very good morning to everyone present here. I am thankful to IPS Sleep Medicine Specialty Section and special thanks to Ravi sir and Dr. Saurav Das, to invite me for this talk. When I was invited by Dr. Saurav for this talk, I was initially hesitant in speaking on this. If Dr. Saurav could recall, I was hesitant to speak on this topic because CBTi is something that I have not practiced in totality, but definitely I try to employ the components of CBT because we all know it is a multi-component therapy that has got a rich evidence base for insomnia. But the topic is about its efficacy on depression. So there lies the catch. So I'll try to do some justice on this topic. So with this, I'd like to start. At the outset, I have a disclaimer that there is no financial, academic, and other conflict of interest for this presentation. And I would be trying to design my talk on these three important and simple headings regarding insomnia and depression, whether they are symptoms, the disorder, the link between these two. What is cognitive behavioral therapy for insomnia, or in short, the CBTi? And the effect of CBTi on depression. We all know that CBTi definitely it has got a evidence base, and according to current guidelines, the European guidelines and other guidelines, has got the robust evidence, the first line treatment for chronic treatment of chronic insomnia in adults. So for depression, we have to go and gather some evidences. We have to know something so that we can translate this practice from the bench to bedside. So insomnia, since like it needs no introduction, we know according to the International Classification of Sleep Disorder 3, the third edition, we know that it's for chronic insomnia, for diagnosing chronic insomnia, there can be multiple things, like it has to be whether one of the five, whether difficulty initiating sleep, difficulty in maintaining the sleep, early waking than desired. And there are two important categories that has been added: that resistance to go to bed on appropriate schedule, and it's a behavioral thing, and difficulty sleeping without a parent and caregiver intervention. So any one of this should be present. And along with that, there should be daytime symptoms in the form of mood changes, fatigue, malaise, lethargy, irritability, daytime sleepiness, reduced motivation, etc. Any one of the daytime symptoms should be present for at least more than 3 times per week, and for chronicity to be established for at least 3 months. This should be there even when there is adequate opportunity to sleep comfortably in bed. Like for example, a worker having a night shift duty coming and telling that I'm not able to sleep at night. So we have to first establish there is adequate opportunity to sleep comfortably for that particular night shift worker. And definitely it shouldn't be explained by another sleep disorder. Now, the major issue with insomnia with psychiatrists lies in the basic fact that whether insomnia is only a symptom or insomnia can also be diagnosed as a disorder. Now, I think this has already been discussed. So insomnia is also a symptom and definitely a disorder. We can always add insomnia as a comorbid disorder, or insomnia can be a standalone diagnosis, provided the criteria gets mentioned and the patients complain that insomnia was something that started before than the other psychological symptoms. And secondly, few questions to the patient, for example, how your mood remains on those days when you sleep good. So if the person tells that my mood symptoms vanishes on those nights if I get a proper sleep, so this qualifies that it is not subsumed within the bigger diagnosis of depression. It can be a separate entity. So insomnia can be a separate disorder. So whenever there is an opportunity for a person who comes with insomnia, that is a standalone diagnosis, we shouldn't refrain ourselves from giving a diagnosis of insomnia as a disorder, whether standalone or as comorbid to other. So here lies the other catch, whether it is a primary and the secondary insomnia. So it's no introduction. Primary, in which there is no other causes, physical, psychological, behavioral causes that can lead to insomnia are the primary. So insomnia and depression has got a bidirectional link. It can be a core symptom of depression. Insomnia can be the initial most symptom of depression. Insomnia can trigger a depressive episode and even of suicide. And it has been also been shown that when treatment of depression has been optimal, insomnia sometimes tend to persist, showing a suboptimal response to standard antidepressant treatment can be the only persisting symptom after an achievable clinical remission of depression and can be a marker of relapse in depression. And as I have told earlier in the previously, it can be an independent diagnosis too. So there remains a bidirectional link between insomnia and depression. So when we are targeting depression, we should at least target separately this biological symptom, that is insomnia. And when we are also targeting insomnia, we should at least assess patient whether there is a comorbid mood disorders like depression, lest things which are severe may go unattended. So coming to CBTi for insomnia, as we know, it's a evidence-based therapy and it has been considered to be the first line for chronic insomnia. It is a multi-component therapy comprising of many parts, starting with psychoeducation, giving sleep hygiene. I think this needs no introduction. There is sleep restriction therapy, in which we try to decrease the denominator, that is the total time in bed, so as to increase the sleep efficiency and keep somewhere between 80 to 85% for a person having difficulty in sleeping. Relaxation therapy is to decrease the somatic tension related to sleep related issues. Stimulus control therapy are related to the lights, and other environmental factors which can prevent achievable adequate sleep amount. And cognitive therapy targets the maladaptive thoughts, the inflexible cognitive errors related to insomnia. So the question lies whether the CBT for insomnia improves depressive symptoms. In short, yes. We should look for evidences. That's what is important. So while I gave a search in Google, in PubMed, regarding with the proper Boolean searches regarding CBT, insomnia, and depression, initially it returned 442 results till today, starting from 2001 to 2023. When a filter of randomized control trial was given, it reduced to around 152 results. But not all of them directly studies depression. It also studied its effect on depressive symptoms as well. So since because of time crunch, I'll be not going on to all the studies, but few studies that caught my attention and are of recent for last 4 to 5 years, which are important, has some robust like uh, methodological methodological standards. Those studies I tried to put for some evidences. So this was one by Cheng et al., in which came in psychological medicine, which tried to assess the efficacy of digital CBT for insomnia to reduce depression across different demographic groups. And it was found that while they tried to compare between digital CBTi with online sleep education module, with a sample size of 358 in the first group and 300 in the separate group, they found that the former, that's the digital CBTi, yielded greater reduction in both insomnia and depression severity than the online sleep education module. Similarly, another randomized controlled trial, which is also known as the TRIAD study, treatment for insomnia and depression study, it targeted the efficacy of CBTi for combined with antidepressants in patients with comorbid depression and insomnia. So it was found that the sample size was 150, and participants with MDD and insomnia were randomized to one of the two treatment arms. Both received antidepressants, while one group received antidepressant with a in-person offline CBTi. The other group received antidepressant with a control psychological inputs. It was found that while CBTi reduced insomnia severity, there were no significant differences in depression outcomes between this. So this was a negative study that linked that there is no significant difference between CBTi on the depression outcomes, though it had effect on the sleep outcomes. Two studies that came in two subsequent years, one published in Lancet Psychiatry by Christensen et al., and the second follow-up study came in BJ Psychiatry in 2017. They tried to assess the effectiveness of an online CBTi module for prevention of depressive episodes and the trajectories of the outcomes. It was a 6-week digital CBTi technique, and the control arm was an internet-based control program, Insomnia, and subclinical depression. So subclinical depression was taken. So PHQ-9 was used, and it was found that the digital CBTi program significantly reduced depressive symptoms as well as suicidal ideations compared to the online internet-based control program treatment. And in the second study, it was found that when these patients were taken up in follow-up, till 18 months of follow-up, the effect of depressive symptoms was sustained, but there was not so much effect on the suicidal ideations in those patients. There are two systematic reviews and meta-analysis. One came recent in April 2022. It was found that when CBTi was looked for in mental disorders across like PTSD, anxiety disorders, depression, and comorbid insomnia in a systematic review and meta-analysis format, it was found that stable medium to large effects indicate that CBTi is an effective treatment for person with insomnia and comorbid mental disorders, especially depression, PTSD, alcohol dependence syndrome, etc. Another systematic review, it also tried to assess CBTi, its effectiveness to treat depression. So here they targeted three group of therapies, whether it is in-person CBTi, whether it is a group CBTi, and some telehealth module of delivery of sleep hygiene practices. It was noticed that CBTi was a promising treatment. So I'm not going to the details of the systematic review, but the authors concluded that it is a promising treatment for depression comorbid with insomnia. And definitely the in-person therapy has the most supporting evidence in efficacy. So this was one study. So this came in 2018 in Journal of Psychosomatic Research. So till this time we have sufficient evidence because we have two systematic reviews on this, and both, and though one of the systematic review and meta-analysis has given some uh, has been ambivalent, has not given so much of uh, like uh, data to show us that it is quite effective in depression. This current systematic review by Jasmine et al. Has told about its efficacy, the most of the in-person CBTi for depression. So even if we go apart from this evidence, if we just go into the clinical practice, so it has been, we normally find that if patients with insomnia gets proper treatment and adequate attention, insomnia, it plays a long way in preventing the genesis of depression. Even if uh, a person with depression complains of lingering insomnia, it's not at all bad to target insomnia separately because we are already giving antidepressant therapy. So it is not bad to at least target the insomnia in a separate domain because both might add up to the overall efficacy in depression. And that's what bench to bedside means. Whatever evidence we gather, whatever evidence we read, that should be translated to what we actually deliver to our patients for an overall betterment. So my take-home message for this would be that there is a bidirectional link between insomnia and depression. Insomnia may not show response with standard antidepressant therapy all the time. CBT for insomnia can lessen depressive symptomology, though we need further evidences, further mode, and mainly mode of, and mainly we need evidences on online CBTi. That is very important. At times, it becomes difficult to use all the components of CBTi in our busy OPD practices, but we can at least practice few, like psychoeducation we can do the sleep hygiene technique. We can at least employ the stimulus control therapy. We can, if we have time, we can at least target the cognitive aspects of insomnia so that uh, the the cognitive errors regarding insomnia gets corrected. That can translate into an overall improvement in the mood symptoms, specifically depression, to this context. I'm again thankful to Dr. Saurabh Das and Dr. Ravi Gupta sir to give this opportunity. Thank you.